And it's very typical not to receive questions during the first lecture, like, I don't know so much about this topic. All right, so for the sake of preserving time, as I said, you can always get yourself stretched and get some coffee, get some snacks. I'll introduce the next speaker, Dr. Alfonso Iorio from McMaster University. Please come and join me in the podium. And Dr. Iorio is going to talk to us about the three components of healthcare decisions: diagnosis, prognosis, and treatment. Alfonso, the podium is yours.
Thank you. Thank you, Fahd. Good morning, everyone. It's always a pleasure. It's the third time, I think, for me to join this workshop. And it's amazing how every time I'll go back to Canada with some change to the material and some good idea to work on to improve communication on EBM. I always also like to give this talk after Fahd's one because it's easier to discuss what we are going to discuss after such an introduction. And we will still stay on a very broad level. The theory about learning tells that you learn much more when you understand the learning need. And there is no point in teaching what you already know or what makes no sense to you because it's not connected with your daily clinical or whatever kind of daily activity you do. So it's not a waste of time to try to show the big picture first, the categories of thinking and classification that we discussed in the introductory lecture, and the basic approach to clinical or healthcare-related activity that we will cover in this first talk I'm giving to you over these 3 days. And then you will have plenty of time of covering the details of the most important study design in the tutorial. And that's another important component of learning. You learn maybe 10% of what is delivered to you in a frontal way like this, and you learn about 30 to 50% of what happened through discussion around a smaller table, when you are more directly involved. Now, we'll try to improve or increase the level of involvement in this second talk, but I'm sure we won't reach any peak before the tutorial. Now, the main focus of this talk is to show you that we need a different component of evidence. We have spoken until now of different study design and different ways of answering questions in different fields with pros and cons of different approaches. Now, let's focus on components of a healthcare-related decision: diagnosis, prognosis, and treatment effect. There are others, but these are the three most important. Now, I want to help you, guide you, or maybe just confirm, if you know already, that EBM is not all about randomized controlled trials. It maybe was that 25 years ago, when there was no knowledge about how to build medical evidence. But now the evidence about intervention effect is one of the components, but is not the only one. We also need to know what will happen to patient and what will happen to ourselves as human beings. What are patient preferences and values? We may know that a treatment increases lifespan by 4 months in oncology, for example, or that a specific surgical procedure will solve a problem. It might create others, and sometimes there is a balance, and that balance is not equal for everyone. There are different patients, different cultures, different professions that patient may have that make some solution better or worse than other. And finally, there is need of looking at evidence about feasibility. We touched already on this, about what can be done in a specific context. So there is an entire body of literature looking at what happens at patients after they develop a disease, no matter if they are treated or not. Hopefully treatment will delay the happening of outcome event, but still, it's important to know how likely is some event to happen. That's prognosis, and prognosis is also dealing with risk factors. And we will go back to every single concept. I'm trying to give you a broad, comprehensive picture. There is literature, but even more than literature, there is a personal life experience of every one of us about what makes the difference from the patient viewpoint in deciding for undertaking a treatment, undertaking a surgery, or changing their lifestyle. A lot has been said, and a lot more is known about evidence of intervention effect. Well, you may well imagine why, because there's a lot of money attached to intervention. There's a lot of pharma pressure on proving effectiveness of medication, and in some healthcare systems, there's a lot of pressure on showing that even interventions that are not pharmacological but are provided by healthcare professionals may have a lot of economic pressure behind them. So there's much more research about what works and what doesn't in this field. And finally, we have to be aware what is available in our own setting, what is acceptable to our own patient. All of this is not working automatically, and that's where EBM has left and created a central role for professionals. There is still need of someone putting all these components together. There is no algorithm that does that for us and send us out of business. Now, this is my view, and is not only my view, is a very commonly accepted view on EBM. Now, EBM in the end is behind making decisions in healthcare. Let's try to build now a decision framework. What are the components of a medical decision? I need 5, I can live with 4, but I won't go on until you pull up these 4. So, volunteers, what you need to know for a rational medical decision. Who's going to go first? I'm not as flexible as Fahd. I'll stay here until you say these 4, so can become 5 or 6 instead of 4. I'm speaking of the end time of the day. So what you need to know to make a decision. We are making a decision for an individual. So what you need to know? History. So you need to know something about that specific case. Good, that's one component. Then, bit louder. Sorry? Knowledge. Knowledge about what? Knowledge about history is all knowledge, but when you say knowledge, is knowledge on what? Scientific knowledge. So, for example, you may be referring to knowledge about the efficacy of what you are going to propose. Okay. 2. We need at least 2 more. Options. Right. Why you need options? There's a loud fan here. I understand that you don't have a microphone, but try to yell a bit. I can't hear. So why you need options? Yes, so you mean option may have different complication and may have different price, may have different impact on life. So the concept of option is related to choosing. If you think of a different field, you want to buy a car or you want to buy a new house. Well, if there's only one you can buy, there's not a lot of decision making. You go and buy or you stay where you are. If you need a car because yours is broken and there's only one model you can buy, you buy, no choice. But if you have a suite of choices, then you pick what you need, what you want. So knowledge about the case, history, knowledge about the treatment, option, so a way of bringing in preferences, and someone said cost. Yeah, cost is, you know, the example of the car makes you consider that yet I might have plenty of options, but I can buy what I can buy. I have a budget. So you need information about cost. Absolutely. These are the 4 components you need to take into account. One representation of a clinical decision making, again, this comes from the early days of IBM, says that you need to know about the clinical state, the setting, the circumstances, all what we called history. So we were right there. We need to have research evidence, what she called knowledge. We need to have a way of matching patient preference and action, which is options, which means that there is no one single decision that is right. And we need to know about resources. So you got all the 4. The tough part was not for you to know, was to make you speak. So please help me going forward. We will learn from each other if we put ourselves on the spot. And then we need, again, clinical expertise. We need to put all these 4 components together. Evidence doesn't make decision. Evidence is that knowledge part. But all the rest is your skill, your attitude to take out of the patient and put together in the mixture. Now, all of this is very easy when you look at it from above. It becomes more of a maze or a mess, depending as you prefer to call it, when you are digging into daily clinical decisions. Now, let's try to use a few examples, or mostly one example across different stages. We, or you, are admitting a young male presenting with shock a few weeks after reconstructive and surgery. Was an accident on the workplace. He has been found unconscious at home by his wife when she came back from 3-day visit to her family. He's hypotensive, hypovolemic, hyperpuretic. Now, if you are in Canada or North America, there's no history here. He got drunk. He was left alone, no wife, no kids around. He just was between the couch and the fridge taking out beers and no history. But we are not in that setting, so what do you think is going on here? Now, let's exercise the PICO framework way of thinking. What's the population? Let's say we want to go and clarify how to attach a diagnostic label to this situation. So we now think of studies helping us to frame this patient disease. What's the population? I need a volunteer naming the population. Unconscious patient. Okay, someone else want to specify it better? Post-surgery. Sorry? Was a male or a female? Male. Might this make difference? Well, it might. It's more difficult for males to have pelvic infectious diseases. It can, but is less likely. So gender, sex may make a difference. Anyways, you are there. I would say, but again, this is subjective, oral males admitted to ICU with hemodynamic compromise. Surgery would have been a good addition, say, with previous surgery. Now, what's the intervention? We are thinking of making a diagnosis. So I'll take this on me, and I would say, let's see if measuring the plasma procalcitonin may be of help. You tell me what the comparator is. What would you use in your, is there anyone here working or rotating in ICU? I'm lucky today. Okay, but any one of you rotated in ICU in the, okay, so you see, if, not now, but they were in ICU over the last rotation. So which test would you do here to rule out or prove that there is a sepsis, an infection? Okay, the white count. Or would you, for example, use a CRP? Yeah, so let's consider CRP. But white count would have been good as well. What's the outcome? Sepsis, yes. So the diagnosis of sepsis. And what's the time frame? When you want this diagnosis done? When? Yes, now, not in a month. It's too late. ICU, you solve everything in minutes, for the good or for the bad, but that's the way. So no time frame now. Good. If we go with this question, the beauty of using the PICO is that we understand each other. We know now that whatever we will discuss from now on will apply to this population, these two tests, and will be relevant to this outcome. So mortality, not something we are looking into it now. Or white blood cell, we are not comparing to white blood cell. Maybe they are better. We are comparing with this specific test. Now, you go, you find a systematic review, you can't read anything, that's intentional. I'll make big the result part, and you see that there are at least 25 studies that might be used, of which 6 more become usable after we ask for additional information from the authors, but only final 15 in the end compare the two diagnostic strategies. So even in a systematic review, there is a lot of evidence, only some will apply. Now, this is the way Gord Guyot wrote all the guide, JAMA guide to the medical literature. Problem is, you usually don't find that review. You don't have it there. And that's where EBM has taken different paths. You know who these guys are? Any of you recognize any of these faces? You're not supposed to, but maybe someone does. So this one here is David Sackett. And David Sackett is the one who created evidence-based medicine, was the first director of the department where I work. He died 2 years ago. And the department is clinical epidemiology and biostatistics. Now we have changed the name. It's health, research methods, evidence, and impact. I'm not sure if David would be happy of knowing that we changed the name, but anyways. He created this way of approaching the literature. This one here, this is John Evans. John Evans was the founding dean of the School of Medicine at McMaster, and he was the one recruiting David Sackett. John Evans came from Oxford, UK, and he was a strong believer that there's no point in talking to students like I'm doing. He said the only way they will learn is learning on the field, is problem-based learning. You affect a bit the mortality of the population over the training period, but it's indeed a very effective way of teaching. Now, the definition of EBM that David gave was the integration of best research with clinical expertise and patient values. And this was in 1977, so nothing new under the sun. What changed later on was that IBM took different direction. You know these guys now? You know who this one is? A few years back, the photo needs to be updated. This is Gordon Guyatt. And Gordon Guyatt is a believer of teach people how to fish. So he was one of the authors of clinical trials. He created the JAMA User Guide to the Medical Literature. The idea is we'll teach doctors how to recognize a good paper from a bad paper. That's critically important, and that's what we will be doing over these 3 days. But it's not enough. It's good to know it let you take responsibility for your decision. You need to know how to do critical appraisal, but what Brian Haynes, they were both direct co-workers of David Sackett. Gore took this direction. Brian Haynes developed the concept of let's help people by giving them pre-cooked fish. So he created a machinery where good quality literature providing answers to important clinical questions is collected and made available for searching. And of course, I'm biased. I think that it's important to know. I'm happy to be here teaching how to appraise the literature. I also think that spending time, energy, and dollars in making the good evidence available is worth effort. And I took over the Health Knowledge Refinery from Brian Haynes, and I'm now on this side of IBM looking after and moving forward the pre-appraised repository we have at McMaster. We will have time of going back to that. In both cases, not all literature is the same. And I showed you a systematic review. I will show you many systematic reviews going forward. And systematic review is important because it brings together all the evidence, all the studies, not only randomized, the case core, the case control. You can do systematic review of everything. And the value of a systematic review is that already all what is known in that field is synthesized in a single paper. So it's quicker for you to use that evidence for making decisions. But it's not on top of the pyramid. You have the single studies down here. They are summarized in systematic review. Then there are guidelines. And more guidelines come to help. Because what's the difference between a systematic review and a guidelines? Well, here we have the evidence mostly on one aspect. You have evidence on prognosis, on diagnosis, on treatment. You don't have patient preferences and values. You don't have cost and healthcare resource use. Here, you have already this component put together. Still doesn't make the decision for you, but brings together the other component. Over guidelines, you have summaries. We'll go back in a while to what summaries are collection of recommendation. You will have exposure to how to search the literature. This is how we present the result of searching through the Health Knowledge Refinery. You find evidence already summarized along the pyramid. These are summaries, Dynamed up-to-date online textbook. And then below, you have the systematic reviews at this level, the studies, and down PubMed. All searched in one single step, so that you can scroll and find the answer to your question wherever you are. Let's go back to the question. Now, the question was, is procalcitonin providing any better clue to diagnosis than CRP? White circle are procalcitonin, and the black triangle are CRP. Now, we will learn, if you don't know already, how to read the forest plot. You have to know, is a log scale here, so this will likely be odd ratio or likelihood ratio. In this case, we are in diagnosis. Doesn't matter, we will learn how to read. The concept is they are both on the same side. In most cases, they fall close. Sometimes the triangle is on the right, sometimes the circle is on the right. So I would not expect a huge difference. And in fact, if you plot them in an easier way to understand about diagnosis, you would go closer as you can to this top corner. So the more you go here, the more the curve goes close to the top left corner, the better the test. And you see that CRP is the dashed line, PCT is the black one, is a bit better, but is not significantly better. Very likely you do well continuing with white blood cell and calcitonin. There's no ideal test that goes up there. That usually assessment of the patient being alive. If he's alive, he's alive. If he's dead, he's dead. Then you have a likelihood ratio up there. But many other tests, they are not so precise. Now, let's assume CRP was high, this patient had a sepsis, or the procalcitonin was above cutoff. You send blood culture, you start antibiotics, and the patient was hypotensive. You also order 4% albumin replacement. Now, one of your resident, the SMR, take you on the side and says, well, I'm okay if you want, but are you sure it's a good idea to order albumin? There's an ongoing audit after a Cochrane review, and it looks like albumin costs a lot and does nothing really good. Do you want to proceed? Now, you are a resident and you know that we staff never trust what you say, and as a minimum, we challenge what you say. So the first thing is, okay, you might be right, but why are you saying so? Well, that SMR was very prepared because he survived up to being an SMR, and I don't know why you can't read. It was readable on my screen, but anyways, he shows you on his phone, and you can barely read because it's past the time you were able to read iPhones, and there is a effect size of about 1. So albumin, crystalloid, gelatin, dextran, there's no effect. Maybe he's right. Now, what's the question here? First way to push back is, let's see if you got it right. Which question is your review answering, and which is our question? Again, in pico term, what's the population here? Sepsis patient in ICU. Okay. What's the intervention? Albumin. So you are a fast learner. Now the delay between the question and the answer is milliseconds. Good. We will make it for 4. What's the comparator? Yes, so crystalloids, or just, yeah, I would say crystalloids usually. You would use something that expand volume with a at least normal oncotic behavior. What's the outcome? Survival. In this case, we are really worried about the patient surviving. And what's the time frame? Well, not immediate, but when you expect to see the effect of the albumin you give today. How long you would go on giving albumin before, or crystalloids, before calling the parents and saying, he's not responding, or calling the surgeon and saying, where is he leaking? So, days. But survival is 1 month. You don't expect to change survival 10 years down the road giving albumin today, right? So you would be happy to impact on in-hospital mortality. So with this question in mind, we go to the literature and we find a systematic review on the role of albumin as resuscitation fluid for patients with sepsis. And this is on critical care medicine, and is pretty recent, and it pulls together 17 studies. Some were excluded because they had no data on mortality, and we are interested in mortality. Now, I'm not showing a forest plot this time. This is a table doing the risk of bias assessment of the 17 studies. Allocation concealment, intention to treat, blinding, and so on. What I'm interested in here is the sepsis subgroup. Some of these studies were done in patients with sepsis. Some other, they just collected information after on the subgroup. Some other, they don't really focus on sepsis. They just enrolled patients with sepsis among other diseases. And this is important because for our specific question, we want that specific population. Risk of bias, green is good, yellow is uncertain, red is a flag for something went wrong in those studies. You see, overall, the picture is good. This is, on average, high-quality literature. You can, this is study by study, and this is instead overall. And you see that overall, blinding was always okay, randomization, allocation were overall good. Where there were some problem was in incomplete reporting and selective reporting. They said that they would have measured mortality and they didn't, and so on. In general, this is a good forest plot. This way of showing bias is typical of Cochrane. Every Cochrane reviews has all these aspects. Now, this is the forest plot. Again, you see most of the studies were not significant. Their confidence interval crossed the identity line. We will go back to what you need to take into account to read the forest plot. I'm sure you know already how to do it. For now, it's just to show you there's a lot of variability. These are the studies on sepsis with the predefined sepsis subgroups. And you see that most of the evidence comes from one single study, the SAFE study. And there is not really an effect on mortality. So your resident was, as always, right, and he saved you from being pointed at as a resource waster, ignorant, unaware of policies in your hospital and country. Okay, it's over. You prescribe crystalloids and all goes well. So at this point, you move the patient back on the ward. On that day, the wife comes to you. She thanks you for all your professional and human support. You take credit also for what the resident helped you doing, but that doesn't matter. That's life. He will have his time later on in life. And she asks you, when my husband will be back to be as he was before, when he will be back to normality? Is that a stupid question, or is an important question? He had a sepsis. He had a surgery, got an infection. Why shouldn't go back to normal? So what's your answer? Again, you may say, oh, 2 weeks. Or you may say, well, maybe this lady is cleverer than I am, and is this man going back to normal? What's the chance? So what's this is a prognostic question now. What's the population here? What? Yes, so these are adult male discharged alive from ICU after a sepsis episode. So that's our population. He made it through, he survived, now he's discharged. And what's the intervention? It's a prognostic study, so she wants to know when my husband will be back to normality. The intervention is? Well, it's really time. There's no intervention. She asks simply, okay, you did great, you saved my husband, now it needs time to recover. How long will it take, and will he go back to normal? So there is no intervention. It's just observing what happened to this population. And again, no comparator, or the comparator is will he be doing any better or worse than those admitted to ICU and surviving for other causes, trauma? What's the outcome? Survival, of course, but also functional status, quality of life. What is the time frame this time? Do you think that she's interested in the next month, or lifelong, or at least until he dies. We know from the previous lecture that she will die later than her husband, so she might be interested functional status until he is alive. So I would say it's lifelong. 5 years is possibly what she is looking into, if she needs to get organized for later, okay? Make sense? So let's go and see what we find in the literature. We find another systematic review, long-term mortality and quality of life in sepsis, a systematic review, 30 trials. So why don't you guess, what is the survival rate in this population? 100%, 0. Where are we here? What do you think? Before reading a systematic review, if you were the one talking to this lady, what would you say? What's the survival expectation for this gentleman? You don't know. I didn't know as well. So in this case, I take your silence as intelligent silence. Here is the answer. You can't read, but I'll show you in a second. You have here the long-term mortality. And if I plot it, you see that you have 3% mortality in one study and 43% mortality in one other study. And you have many, around 30%. Were you expecting such high numbers? Well, I think not. And the reason is an infection after surgery is not that rare, but it's not so common to end in ICU. So there was something there that makes this case and all the cases that went into these studies not so simple. Now, a lot of variability, difficult to give an answer. Even if we look at mortality at 3 months, 6 months, 1 year, you see 1 year goes from 3% to 43. 2 years goes from 15 to over 50. And the same symbol is the same study. You see that there is a trend. So we know that the uncertainty is huge, but we also know that when you follow in the same study over time, there is a trend, which means the data are somehow robust. We don't know exactly where we are, but we know that these are true data. And if you look at total mortality, so not mortality after discharge, but total mortality, there is less variability and even a more linear approach. The bottom line is she's right to be worried. It's difficult to frame the chance for this patient to have other problems, but is not 0, and very likely is higher than 10%. Okay, I have one last example. Before that, I want you to stretch for a second, and so to help you stretching, I'll ask you questions. So you have to raise your arm, which is a good exercise. And actually, since the most horrible complication of courses like this is DVT, because you stay sitting immobile and you can have a DVT forming. Well, you are young, so it's not likely, but let's assume you have DVT forming in your legs, and then when you stand up going for coffee, you drop down dead. To avoid that, you can answer even with your feet if you prefer, but you have to answer. Now, who of you combine evidence for diagnosis, prognosis, and treatment in the clinical decision you make in your daily practice? Who does? I do. Anyone else does? You do, you do. Okay. Who of you think is wise doing so? After being exposed to what prognosis is, what diagnosis is, and what treatment is, do you think it's wise to decide taking these 3 components into account? Who think is wise? Okay, I do. I do because I think it's wise. Okay, very good. Who of you does use any source of pre-appraised evidence? She does. Raise it. It works better if you raise it high for exercise, I mean, and for me to see. Who does? 1, 2, anyone else? Only 2 in this room? Okay, 3, 4, 5, sorry guys, I forgot the left wing. And okay, so there's a minority of you using pre-appraised evidence. Who uses up-to-date? Okay, so you use pre-appraised evidence, you just don't know that you are doing, because up-to-date is pre-appraised evidence. They take literature, they read it, they appraise it. You know, their editors, they get a course like this every other month, because it's not easy, and the hope is to make them better in doing their job. But that's pre-appraised evidence. Who of you use Dynamed Plus or knows what Dynamed Plus is? Dynamed Plus is like up-to-date. It's just another publisher, another textbook. But is exactly the same thing. Is taking the literature and organizing it in a sort of a textbook to make it easier to use it. Again, pre-appraised evidence. Who is registered with an evidence alerting system? Who receives emails telling you, do you know about this new study? You do, okay, good. I'm not asking you which one you are registered for, because we have one and I would be offended if you were registering to someone else. So I'm not asking if you register to Medscape or Journal Watch or McMaster Plus. I'm sure you register to McMaster Plus, okay. Now, my last example is just to reiterate the concept. It's a different setting, it's a different clinical decision, so we leave alone the poor young adult with sepsis that now is trying to convince his wife that he will live long and be healthy, and we'll move to a different decision. But we'll use the same criteria and the same approach. So again, nothing new. And we'll try to prevent viruses to enter into cells and cause disease. Even if these, as you will likely recognize, are not viruses and receptors, but is an aerial photo of Dubai. But sounds very similar. So the patient you saved, the one in ICU, actually was the owner of a high-end retirement home network and offers you a job as vice president, medical director of his enterprise. And your first task now is to address a preventative plan to reduce cardiovascular mortality associated with influenza. Does influenza increase cardiovascular mortality? What do you think? He's shaking his head. He says, oh, I'm not sure, but it doesn't seem that impossible that influenza will increase cardiovascular mortality. Now, there are a few, there were actually, because times goes, but 2009, 2013, 15, many reports showing an association between influenza and cardiovascular mortality. It's not easy. So Fahd before told you that one of the values of course study is that it helps you making hypotheses about causality. Is that true? You can't get any clue about causality in a case control or in a cross-sectional study. But even with core study, you can make hypotheses, but really to prove causality, you would need a randomized study, because you are sure that the two populations are different and whatever exposure is causing the outcome. In a cohort study, there is still a possibility that the exposure is associated with something different, and that something different is causing the outcome. But unfortunately, for some situation, you can't do a randomized study. You can't randomize people to get or not the flu. You get it, or you don't. You can randomize people to get the flu vaccine, yes, but to get the flu or not, you can't do a study. Like you can't randomize people to smoke or not. Either you like to smoke or you don't. Either you think it's harmful and you don't do it, or you do it, but it's your free choice. You can't randomize people to harm. You can't randomize people to live close by a nuclear plant or not. If you are lucky, you live far. If you are unlucky, you live close. But you can't randomize people to go live close by some risky place. So there are situations where you cannot do a randomized study, and you have to live with the hypothesis generating cohort study and try to be sure there is no bias. There's a lot of bias. Again, this is not a talk about bias, but just to set the stage to answer this question, these are three atypical or uncommon kind of bias that might be at play in cohort studies. The healthy user bias, the one getting the vaccine are healthier than the one not getting the vaccine. They also go to the gym, they also adhere to a diet, they care more about their health, and that's why they get the vaccine. And of course, they might get less cardiovascular events. Or vice versa, you might be in a different healthcare system where flu vaccination is provided for free to frail elderly people. And you get to vaccinate those more at risk. And your core study in the second setting will show no effect in preventing cardiovascular disease. It's so high among those getting the vaccine that even if you reduce it, will be still higher than in those not receiving the vaccine. In the first setting, healthy user bias, those will have less cardiovascular events, no matter if they get the vaccine or not, just because they are healthier. So these studies would be confounded. The most concern arose from showing that the mortality in those receiving the vaccine was less in the summer. What that has to do with the vaccine and flu. Flu is, the outbreak of flu is in the winter, spring at latest, but not in the summer. So how can a vaccine that you get in November prevent flu that happen in the spring or winter and the mortality decreases in the summer? There might be something wrong there. So it's not always easy to interpret the literature. Again, I'll save you to spell your PICO question, but I want you over coffee break to talk to each other only in PICO terms, nothing else allowed. Use your fantasy. If you have to tell about what you did over the weekend, that has to be in PICO terms. But let's go and find the literature, a literature review, a systematic review. Meta-analysis of case control studies. Now, Fahad told you before, you only use case control study when you deal with rare diseases. Well, flu is not a rare disease. Is myocardial infarction a rare disease? No. What's rare? The combination. Myocardial infarction in people with flu is not that common. I mean, if you take two common diseases, the combination is likely to be common. But being able to tell this event is associated to flu, that's a rare event. That's why you use a case control study. And also for case control study, you can do a meta-analysis, a systematic review. They did it. They found 16 publications. This is a prisma diagram where you start, what you eliminate, what you are left with. You can use a consort diagram in a clinical trial. I enroll 1,000. Some I exclude for a reason. Some I lose during follow-up. Some I can't assess for the outcome. This is what I'm left with, consort diagram of a study. or in a systematic review, exactly the same. It's called PRISMA, and you start from how many studies you found initially, how many you use. Look at these plots immediately when you apply your firm algorithm to decide if you read that study or not. I would also add, if there is no PRISMA or consort diagram, it's likely be a mess to understand what they did. If you have another, prefer the other one. As a reviewer, I always put as a mandatory point for paper I accept that they should come up with one of these diagrams. Now, of the 16 study, the bottom line is 2 times more cardiovascular event in patient having the flu. So it seems to be associated. Now, if I tell you that there are twice as many cardiovascular events in patients developing the flu, would you feel comfortable suggesting your patient to get a flu vaccination to reduce cardiovascular mortality? Who would feel comfortable? Who would not feel comfortable? No one? Come on. Just because it's associated, you would say, I'll give you a vaccine? There's an important missing piece of information there. To give the vaccine, you have to have evidence that giving vaccine prevents the flu and reduce the cardiovascular mortality. Maybe the vaccine increased the cardiovascular mortality. So having evidence of an association doesn't mean that if you change the rate of flu, you will reduce cardiovascular mortality. This is the commonest mistake in medicine. You see an association, fish consumption and cardiovascular mortality, and you decide everyone has to eat fish, and then everyone dies of some other disease related to fish consumption. So it is okay. If there was no association, okay, let's go for coffee. Nothing more to discuss. But the association is the first step. Then you need to show, and this second meta-analysis, that all those, on average across studies, those getting vaccinated, they have a lower mortality. Those with the flu are on the right, they die more. Those vaccinated die less. Now you are welcome to raise your hand. Now you have enough evidence to say, I'll go and prescribe vaccination for flu to the population I care for to reduce cardiovascular mortality. If you have got this point, if I now ask you, what about early diagnosis and treatment? Of course, you can give vaccine, but you know, vaccine works in a proportion of patients. You can still get the flu, even if you got the vaccine, particularly if our colleagues at the CDC and vaccine pharma, they get the strain of flu that will be circulating wrong, which is very common because flu is tricky and it evolves continuously. The virus changes continuously, and you need months to prepare the vaccine, and you need to have it on time to be able to sell it. So at some point during the summer, they do some forecasting of what is likely to happen. There are sentinel centers in Asia, usually is in East Asia, that flu starts. They characterize that virus, do the vaccine, and then some other virus gets to prevail that year, and the vaccine was useless. Billions of dollars wasted, and people get the flu and die. So what about early diagnosis and treatment? Do we go for that? No, we don't, because before we need to see if that works or not. We have seen that the flu is associated with cardiovascular mortality. We have seen that vaccination can prevent cardiovascular mortality. Now the question is different. Is early diagnosis and treatment, are early diagnosis and treatment able to not only make the flu better, but reduce cardiovascular mortality? So what's the PICO here? The PICO is in patient with diagnosis of flu, would treatment for flu. What you imagine can that be? Amantadine, oseltamivir, this kind of antiviral treatment that were really studied for the not for the standard flu, but for the avian flu, would provide any benefit. Now, how do you do the diagnosis of flu? Symptoms. On symptoms, you would end in treating a lot of patients, because distinguishing a true flu due to the influenza virus from a trivial cold is not easy, particularly if you want to treat day one. So you might imagine you want to search for the virus, and then it's not easy. You might not have that available at your place. There are POC testing. Now, if you recall this scenario, you are working in a high-end healthcare facility where they might have a lot of money. So you might want to consider point-of-care testing for flu. And then, of course, you have to consider how would you treat, which of the medication I would use. So you see that, again, you need information about the association, the prognosis of patient, and you need information about diagnosis and treatment. Now, I'll show you one systematic review on the accuracy of rapid influenza diagnostic test. Again, a meta-analysis, 159 study. Is a very, very lucrative field and market. There's a lot of people trying to make money out of flu, and a lot of tests has been proposed. In general, this is a different way of showing the risk of bias. Green is good, dark green is good, light green is bad. In general, studies are good for most of the item. There is some concern about blinding and about clinical data collection after the test. But in general, is not that bad. And what they show is that, yes, the rapid test is showing what bad is having this line flat here on the diagonal. It's like tossing a coin. Doesn't make a test that has a flat line here doesn't make any difference. Every time the curve goes toward the top left is good. This is very good. And indeed, if you express the performance of the test as likelihood ratio, the likelihood ratio for a negative test is 0.4, which means if your chance of having the flu is 100% before the test, because clinically it might be flu, after a negative test, your chance of having a flu is 40%. But if your likelihood was 100% before the test, after is 3,500 times likely. So it's very, very likely. Which one of these two is useful? Oops, sorry. Well, this one is useful. It means that all those with a positive test very likely have the flu. While for those with a negative test, you cannot really tell, because 40% of them still have the flu. So the likelihood ratio is good when the positive is higher than 10, and is bad when the negative is higher than 0.1. So the negative to be good should be less than 0.1, which means after doing the test, my expectation for that patient to have the disease is 10 times lower or 10 times higher. In choosing the test, it's important to choose the test that change your practice. If a test doesn't change your feeling about that patient, then you would do the same no matter what the test result is. Don't ask for that test. Which is why we shouldn't be asking for routine lights or routine CBC. We don't even read them, and they don't usually change what we do to patients, so there's no need of doing them. In this case, the likelihood ratio for a positive test, John Longenecker will come back on this and will give you an amazing lecture about to calculate and interpret likelihood ratio. But I told you that I was giving you just bites here and there. about what we will be covering during the course. So the test is there. If you convince your healthcare system to buy this test for you, you can make a positive diagnosis of flu and you can then treat those patients. Now for treatment, this is the evidence. Oseltamivir, myth analysis, and you see here cardiac disorders. You have a risk ratio of 0.5. Is it good? 0.5 is good? What does it mean, 0.5? 0.5 means that you reduce mortality by 50%. Well, mortality, you reduce cardiac disorder by 50%. Would you recommend something that reduces the incidence of myocardial infarction by 50%? Who would prescribe? She would? They would? Okay. I can't say you are wrong, because indeed you are reducing cardiac event by 50%. But how big will be the impact of your prescription in your population? Can you tell? You cannot, because the impact on your population will not be based on the relative reduction, 50%. If there are 100 events, by reducing by 50%, you will save 50 people. But if there is one event, in treating 100 people, you will not save one. You would need to treat 200 people, where there would have been 2 events, to save one. So it's still good, you are not killing anyone, but this information is still too little to decide, because you don't know what your number needed to treat is. You don't know how many events you will be saving, and you can't tell to your patient that has to pay for oseltamivir, it's very expensive, and has side effect, how important it is to take. If you get to the true number, in the placebo group, there was 1 event every 100 patients. And so if you reduce by 50%, you will save 1 event every 200 patients you treat. So you can do it, of course, but only 1 patient every 200 of those you treat will have 1. So you would need to treat 200 patients, of which 199 will be treated for nothing, and only 1 will benefit from that treatment, and you'll save 1 cardiovascular event. Now, problem is that we would all like to know who is who, and treat only that one. If we can, well, that's the good way to go. And that's where, again, clinical prediction guide and prognostic literature help us. But if we don't know, we have to decide, do we treat 200 people to save 1 event? The usual answer is no, you don't. It's too much waste of resources and too much exposure to side effects to do it. And these are not necessarily a deadly event. So there is no one recommending doing oseltamivir to all those diagnosed with flu for cardiovascular disease prevention. You can do it because you decrease the duration of hospital stay, you decrease the lost productivity and so on, but not for preventing cardiovascular mortality. Now, my final slide is a sort of summing up. Frame your question correctly. The first point is be sure you are reading something that is relevant to your need, your patient population, your intervention, and is affordable. You need to build your knowledge base covering diagnosis, prognosis, and treatment effect. Many clinical decisions take into account having done a diagnosis or doing a diagnosis, knowing that something bad will happen to the patient. If not, we don't have any problem to solve, and knowing that the treatment we are considering is effective. Whenever you look into the literature, give preference to systematic reviews, even when you read UpToDate or Dynamed. They provide you answer based on systematic review when available or on single studies when there is no systematic review. Where there are systematic review, as we will see during this course, we have much broader confidence that we can follow what the evidence tells us. You have to learn which study design is appropriate for your question. Even if you don't do your own critical appraisal, you have to understand which studies are needed to answer your question. And this last point, the one that I showed you on the flu case, treatment of flu, we will come back on this. Always consider that there are reasons to use a relative measure of effect. There are good reasons, we will discuss them, but when it comes to clinical decision, what counts is the absolute measure of effect. What counts is the number needed to treat. What counts is how many events are you saving, not by which proportion you are decreasing an unknown number of events. Here I stop. Thank you.
Thank you so much, Alfonso. That's great. So just a couple of housekeeping comments before we break down. So we have 5 minutes to go to our groups, check the map, and make sure that you're in the right group. You'll find your name. There's a name plate for you, so a seat assigned for you. So just try to find that seat and have yourself comfortable. There are coffee breaks inside the rooms. Don't worry about missing coffee from here. There are coffee stations inside the rooms. Each room will have its own. So get yourself familiar with the group as well, and serve yourself with a coffee and snack. For the rooms, all the rooms will be through these wooden double doors, except for one room that is on that's the red group. It's going to go from, you just exit from the glass double doors and then take a left and another left after the spa. And we distributed the evaluations, so you got 2 evaluations. Please fill them for the previous 2 lectures. And we'll keep supplying you with evaluations throughout the course. Keep filling them and save them with you, because we're going to receive them on the last day when you do the final exit from the workshop as well. Lunch break is at 12:30, and as we said, you have the literature search session based on the color code that you have. Make sure that you stay in your room in that designated time, because that's the time when you'll see Dr. Abir al-Bahau to talk about the literature search. And I guess that's it. We'll see you online.